constructed towards the University of West Indies MBBS exam. And so I have concocted and constructed this course such that everything that MBBS can bring is what I try to cover, right? It's different, very different to USMLE and MRCP, even though you do question banks from there. This is as specific as it gets towards the MBBS exam, right? So it's based on probably this will be 8 years of research, let's call it research, and familiarizing myself with what the UE MBBS brings and realizing that there are patterns to what they bring and they hardly test outside of what I teach. And so my previous year groups, when they went into exam, they thought I had the paper beforehand or anything. It's nothing like that, right? It's just easy to predict based on the patterns that they have. So before I begin, I just want to also point out, I was trying to coin a term. And the term I came up with was dynamic thinking with constant repetition. What that means is, as we go along, you'll see how I teach. How I teach is how I think, and how you all should start practicing thinking if you're not doing it as yet. You don't want to be myopic and you don't want to think about one specialty. As a clinical practitioner, as a doctor, you want to think about every single thing related to anything you see. So for example, you're going to see here one of the complications of myocardial infarction might be that of one of the 3 to 7 day complications, ventricular free wall rupture and cardiac tamponade. So when you see cardiac tamponade, the dynamic thinking would be, hey, I have also seen that in general surgery as part of probably my chest trauma topics, right? So you say, okay, cardiac tamponade, it's in internal medicine. It is also in general surgery. So now I have to look at it from a gen surg perspective. And you remind yourself about Beck's triad and so on, pericardiocentesis and all of the things you need to know from gen surg. So thinking dynamically means when you see one thing, it prompts you to think about more. And that is going to help, that mind frame and that way of thinking is going to help significantly because your exam is blended. It's also going to help in your career because when something presents looking like one thing, it could very well be another thing. So always think about everything all at once, and that's what I want to have you in the habit of doing. So you will see that there are a lot of by the way teachings that I do. Okay. So I think most everyone is here. I'm going to share my screen now. Right. Ooh. Okay. All right. You'll see in the screen there. Excuse me. Yeah, Christina. Oh, Christina, you're here. Okay, Christina. Hi. Thanks, Lynn. Cool. Are you all just asking? Are you all seeing my chats and participants opened, or you're just seeing Dr. Knight's principles and practice of medicine? Okay, fantastic, right? Because I will keep my chat open and the participants so I can accept them as they answer. Right. So how this goes is we'll do some MCQs again, as I said, as you become more familiar with how I teach, it becomes easier to follow along. But I usually have you all answer the MCQs in the chat. Once you answer the MCQs, you move on. I have a couple MCQs consecutively, and then I teach I teach the entire topic, come back to the MCQs, answer it, and teach around the MCQ as well. So I try to facilitate learning the most important points as relates to MCQ, and also consolidating that with general understanding of the entire topic. So it's pretty interesting. You'll see how as we go along. Additionally, guys, I do a lot of by the way teaching. All right. So I recommend you have your pen, paper, book, or whatever, because a lot of what I say, you need to write down as well. I have this new feature here. Let me see that I added. You all seen the paint screen now? All right, fantastic. Right, so when I need to illustrate, I can illustrate. I didn't have that before, right? So Christina, Sarah, it's going to be better this time around. So I do a lot of by the way teaching, and that is to facilitate the dynamic thinking with constant repetition. So when I see something, I also teach from the top of my mind. So whatever sparks interest, whatever jogs a memory, I will go on and explain it because it would have sparked an interest and jogged the memory because it's most likely I've seen MBBS asked about it. So I just teach as you go along. It's really just a flow, and whatever comes to mind. As by the way, I recommend that you also take that down because it means that my mind is telling me teach you all this because it has come already and it can come again. All right. So make sure you have a lot of paper and writing material because what I say is going to be critical to what may come for the MBBS final exam. Okay, so um, anything else, guys? No recording, no sharing, no distribution of my material. I had that disclaimer already. Um, anything else I remember to say, I will say as we go along. Okay, so for now. Once you've seen my screen, I'll see that you're seeing the painting and everything. Oh, the last thing before I start is the guide. So this guide here, I want to explain that this guide is for me. Okay, I had made this guide for me to guide how I teach and to make sure I don't forget topics. I look at the guide, I glance at the guide to teach, but I don't read off of the slides. Okay, so if you find that when I teach in, I'm not on the same page, then it's because I'm just talking at the top of my head. You all can try and follow along. It usually is in an order. I usually will have it on the page discussing the topic that I'm talking about. But the guide is pretty useful because I have a lot of information. Everything on the guide is relevant to MBBS, right? So I try to make it as succinct as possible to help you all when you're revising, just focus on what you need to know and the buzzwords for exam, okay? But the guide is primarily for me. So you can make adjustments to the guide as you go along, etc. All right, but it's for me to guide my learning. You all have access to it. Please do not share or distribute the guide as well. Okay? So you all are hearing me clearly and loud and clear? Christina, Leah, Celine? Okay. All right, cool. All right. Dr. Amnaran, it might be a phone, right?
Could be, thanks.
Yeah, no probs. Okay, sorry, Fina is here. All right, guys. So enough talking. I will talk a lot as we go along. We are going to get into the interesting part. Vicky, please do not answer any chat because we know you know these things. But guys, as soon as I get 10 answers, I move on. So what that means is the space of the class is also determined by how fast you'll answer my questions. All right. So type. I'm seeing two people trying to enter and I do not know who they are, so I'll leave them out for a while. Okay. All right. So we'll start with question number one. Question number one. Answers in the chat, please. Question number one. Answers in the chat, please. Thank you. Okay, fantastic, fantastic. So we have a few, mostly B's, but we have a couple A's as well. So we'll answer that. Oh, okay, that's you, Shawana. Thanks. Yeah, because I was seeing the Life Academy. I didn't know who it was. Yeah, so we'll answer the question after, right? So just type in the answer, remember the question, and we'll answer after we teach to see if you all had learned anything, to confirm is it B, is it A, or is it not any of those options, okay? So that's number one. Nice. We'll do number two. So answers in the chat to number two, please. Answers to number two, please. Okay, thank you so much. I saw some D's, mainly D's, but I think I saw a couple of B's in there as well. All right, cool. And before we go on to teach our first topic of the day, which is valvular heart disease, let's have the answer to number three, please. Number three. Now, this um, is very similar to a pediatrics question that I would have seen in the 2024 June paper. So let's go. So we've seen A's. Okay. All right. So we saw A's and one B and two B's. Okay. All right. So we definitely have some teaching points on specific. Thank you everyone for participating. And we will begin to teach now. Okay. So, not like here. Okay, cool. So guys, if at any point in time anyone has any questions or needs me to re-explain something, please hesitate not to. You hear me now, Christina? Better? You all hearing me now? Clear? Everyone is hearing me clearly now? Sorry about that. All right, cool. Right. So if any concerns, queries, questions, please don't hesitate to unmute or type in the chat. I prefer you unmute because I wouldn't always have the chat open, okay? Good. Great, guys. So we're going to start teaching now. And the first topic we're going to teach would be that of valvular heart diseases. Now, this is one of the most commonly tested topics in the MBBS exam. And usually, there are three that they test: HOCM, aortic stenosis, and aortic sclerosis. And this represents the ejection systolic crescendo, decrescendo murmurs. Okay, so crescendo, decrescendo murmurs at the upper sternal edge are a favorite of the examiners. And so we're going to start speaking about HOCM. Then we'll speak about aortic stenosis and sclerosis and differentiate them. And then we'll talk about the mitral murmurs as well as the tricuspid and pulmonary murmurs. Now, they are tested in terms of frequency in that order, with the aortic and mitral being tested most commonly, and the right-sided heart must being the right-sided heart valve, pathology being tested least commonly, with tricuspid regurgitation having a new question last year, December and June as well. So I've seen it twice. So they now start to test tricuspid regurgitation. Great. So we see in this screen. We see in this screen. Yeah. Let's make sure we see in the guide. That's right. Okay, great. Right. So the first thing in terms of understanding your heart murmurs and your valvular heart disease would be the surface anatomy of the heart versus the actual anatomy of the heart. So the surface landmarks of each valve, you all should know, would be all physicians take money. Looking at 1, 2, 4, and 5. That is the right upper sternal border for aortic, left upper sternal border for pulmonary, left lower sternal edge for tricuspid, and at the apex for mitral, right? Now, what I want to teach you here is this mnemonic that is RILES, right? So notice that this is the anatomy of the heart. And so your left-sided heart valves are your mitral valve and your aortic valve, whereas your right-sided heart valves are your pulmonary valve and your tricuspid valve. So that's the landmarks of the valves on the heart's anatomy itself. However, when we get to the surface anatomy, the aortic valve is actually on the right side of the chest, and the tricuspid and pulmonary valve are on the left side of the chest. So the right-sided heart valves are actually auscultated on the left side of the chest. Now, the importance of distinguishing this teaching or this point for Riles is that Riles stands for right-sided murmurs allowed on inspiration and left-sided murmurs allowed on expiration. That right and left has to do with the anatomy of the heart, not the landmark, not the surface markings. So your right-sided heart valve, that is pulmonary and tricuspid, are louder on inspiration, whereas your left-sided heart valve murmurs, that is aortic and mitral or bicuspid, that is louder on expiration. So the left-sided heart valves are louder on expiration, right-sided heart valves are louder on inspiration. And I'm teaching this because when you are doing your accentuating maneuvers for your OSCE, when you have the patient left lateral position for your mitral murmurs, you want them to exhale and hold because it is loud on expiration. The same thing for your aortic maneuvers. When they sit up and lean forward, they exhale and hold. So it is louder at the end of expiration because they are left-sided heart valves. All right. So that is that. I wanted to make that very clear. When you're speaking about murmurs, you want to have the characteristics, grade, time, and location, radiation, and accentuating maneuvers considered in terms of describing them. And where that is relevant, I will describe each as we go along. All right? So that is just an introduction. So the valves are aortic, pulmonary, tricuspid, mitral. We'll start with HOCM first, however. So hypertrophic obstructive cardiomyopathy. This is commonly tested in the MBBS exam, and everything I tell you is everything that they test and everything that you will need to know for the rest of your studies. Okay? So for HOCM, look at where the defect is. In hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, the interventricular septum is thickened. When your interventricular septum is thickened, that means that the space, the ventricular space for filling is narrowed. And so therefore you have a left ventricular space narrowing. And also because of the septum protruding this way, you have a left ventricular outflow obstruction. So that is the pathology and pathophysiology a little bit about HOCM. So it is the septum that thickens and that narrows your ventricular lumen, and that also obstructs blood from coming out. That's why you're going to have a murmur, and that's why you're going to have symptoms. So for HOCM, what they love to test is the presentation, the features of the murmur, and the treatment. Okay, that's the three things you need to know about HOCM. So the presentation of HOCM is syncope, angina, and dyspnea. That is SAD, syncope, angina, and dyspnea, but primarily in young, otherwise healthy patients. Okay, so it is an autosomal dominant condition, so it happens in young patients. Contrast that with what we'll see in aortic stenosis that happens in old patients. All right, so they present as syncope, angina, dyspnea in young patients, particularly when they exert themselves. All right, another common presentation of HOCM is that of sudden cardiac death. And sudden cardiac death may actually be the initial presentation and manifestation of HOCM. So if you think about anyone who watches sports, when you see an athlete suddenly collapse on the field, is one of two things. It's either going to be neurogenic or cardiogenic. Most of the times, it's either arrhythmia or HOCM. All right, if it's not an arrhythmia, it's probably HOCM. Young, otherwise fit athletes, sudden cardiac death, HOCM is how that is how HOCM presents. The other thing you need to know about HOCM is the murmur, guys. HOCM is exacerbated by Valsalva maneuver. HOCM is exacerbated by Valsalva maneuver. Out of all these murmurs, HOCM and sometimes mitral valve prolapse is exacerbated by Valsalva maneuver. But by far, this is the distinguishing feature in your question stem for a HOCM murmur, exacerbated by Valsalva maneuver. It is described as a crescendo decrescendo ejection systolic murmur, and it is heard at the left sternal edge. So it's a crescendo decrescendo or ejection systolic murmur at the left sternal edge that is exacerbated by Valsalva maneuver. We'll contrast that when we reach aortic stenosis to show how that is different. The exacerbated maneuvers are quite different, and the location may be different for aortic stenosis as well. Other features of HOCM that I want you all to take note of is that of a double apex beat, a systolic thrill at the left lower sternal edge, and an A wave in your jugular venous form. I do JVP waveform on Thursday, okay? So the double apex beat, the systolic thrill at the left lower sternal edge, and then your ECG findings of HOCM are imperative to know. Mainly atrial fibrillation being seen in HOCM, Wolff-Parkinson-White syndrome, as well as progressive T-wave inversion. You may also have some left ventricular hypertrophy in HOCM, and that is represented by your increased QRS amplitude. Okay? So HOCM is a young patient presenting with syncope as initial presentation, chest pain and recurrent dyspnea, or sudden cardiac death. They may have a strong family history of sudden death. And that is because the condition is autosomal dominant. So when they say the patient coming with syncope and angina and he has a family history of death under the age of 50, that is HOCM until proven otherwise. All right? The murmur is crescendo, decrescendo, ejection systolic at the left sternal edge, and it is exacerbated by Valsalva. Other features are double apex beat, systolic thrill, A-wave in JVP, and of course AFib with Parkinson-White and LVH on your ECG, right? So that's the most important things to know in terms of presentation. And finally, the treatment they love to test. Now, the first line medical treatment for hypertrophic obstructive cardiomyopathy is that of beta blockers, preferably cardioselective ones such as metoprolol. Metoprolol is fantastic. Sometimes you use carvedilol as well. So beta blockers are first line. However, you can use verapamil as first line. But if you have a question where you're choosing between the metoprolol and verapamil, please choose the beta blocker over the CCB. Okay, so write that down, beta blocker over CCB in your MCQs. All right. Next would be the option of septal myomectomy. That is surgery. Myomectomy, muscle cutting, septal septum. So you cut in the muscle, and that is an option for HOCM, but that is only reserved in extremely severe cases where the patient is recurrently symptomatic and their risk of sudden cardiac death is high. All right. So one of the other things that we do to prevent symptoms and to prevent that sudden cardiac death, we always ensure the patient is adequately hydrated, and of course, we don't want them doing any strenuous activity. Okay, so this is probably every single thing that they test on HOCM in a nutshell. Any questions on HOCM so far, guys? Are we clear? Are we following along? Clear? Christina says clear. Is everyone clear? Fantastic, right? So let's contrast HOCM now with aortic stenosis. So what's the difference in how they bring? So sometimes MBBS likes to bring you just the murmur with no clinical demographics or age of the patient. They just tell you the patient has an ejection systolic crescendo, decrescendo murmur at the upper sternal edge. They never say left, they never say right. And all they are going to tell you is that it's either worsened by Valsalva maneuver or that it radiates to the carotids. And that's how you're going to differentiate it, right? The exacerbating maneuvers and the radiation. So for HOCM, it's exacerbated by Valsalva maneuver. For aortic stenosis, what do we need to know? The murmur of aortic stenosis is an ejection systolic crescendo decrescendo murmur, and it can be heard at the left upper sternal edge as well, but it is most commonly heard where's the surface marking of the aortic valve, the right upper sternal border. But an aortic stenosis murmur can be heard at the left sternal border and even throughout the heart at the apex as well, right? So just bear that in mind for your OSCE. But for your question stem, the feature that is going to make this aortic stenosis, if they bring the murmur alone, is the fact that it radiates to the carotid arteries and it is louder on expiration, because we said the aortic valve is a left-sided heart valve, left louder expiration in terms of riles. Right inspiration, left expiration. Aortic valve is left side, it's louder on expiration, and it radiates to the carotids. Okay, so other clinical features that make aortic stenosis your diagnosis or most likely diagnosis would be these very important things to look out for in your question stem. That is, if they give you a blood pressure and the difference between the systolic and diastolic is less than 25, we call that a narrow pulse pressure. Okay, so look for a small discrepancy between your systolic and diastolic blood pressure. That's a narrow pulse pressure seen in aortic stenosis. Another clinical feature that can come in MCQs is that of pulsus parvus aetatus. Parvus aetatus, that is slow and late. Okay, so what that means is think about aortic stenosis, right? The heart valve, let's see if we could try and teach this a little bit more. Let's see if I could use this thing here. I never used this before. So all right, so let's see aortic stenosis. So Let's see, this is a aortic valve. This is a normal aortic valve here. And then for this one, we're going to put it in red. We have a narrow aortic valve, right? So blood has to pump out of the aorta to this narrow valve, okay? Here, it is pumping normally through an open valve. However, if your aortic valve is narrowed, that means that the blood is going to be pumped out, what? Slower and less, okay? So that means when your heart contracts, but you palpate your carotid pulse, they would not be synchronous as they ought to be. So in terms of when your heart contracts, the systolic contraction, when you palpate the carotid pulse simultaneously, it will be slowed and delayed. All right, and so that is that for what pulsus parvus aetatus means. Okay, so that's a slow and delayed heart pulse. Okay, so that is a feature of aortic stenosis as well. Other things to include, I saw this in one question many years ago, is the fact that aortic stenosis has a single S2 and a quiet A2, that's part of the S2, but a single S2. So normally we have a split S2 song in normal because our aortic and pulmonary valves close in that manner. Aortic closes first and then pulmonary would close. But in aortic stenosis, we have a single H2, so it's not split. All right. So that is something I saw in a paper, so you can make sure and highlight that as well. All right. So that is aortic stenosis. Ejection systolic murmur radiating to the carotids. Third loudest at the right upper sternal border, and louder on expiration with the patient leaning forward, of course, associated with a narrow pulse pressure and pulsus parvus aetatus. Now that is if they bring the question with the murmur alone. However, what if they decide, all right, let's make it easy for you, let's give us the clinical presentation, and the clinical presentation of aortic stenosis is the same, SAD, syncope, angina, and dyspnea. The main difference is that it is seen in elderly patients mainly. And so when you have a patient with syncope, angina, and dyspnea, and they test in a murmur, you want to look at the age of the patient. If it's a very, very, very young patient and the murmur is exacerbated by Valsalva, it is likely that that patient has HOCM. If it's an elderly patient, that crescendo ejection systolic murmur radiates to the carotids and louder on expiration, that is aortic stenosis. But we can have aortic stenosis in younger patients. And so if you have a younger patient with aortic stenosis murmur, what you want to think of is a bicuspid aortic valve. Okay? So the causes of aortic stenosis would be senile calcification. That's as they get older, as a patient gets older. We can add to that, let's say, the age more than 70, right? Oh, shit. All right, I'm not going to end this, right? So age more than 70, you could put that up. Then your aortic stenosis is likely due to calcification, senile calcification. If it's less than 70 years of age, you're probably thinking something like a bicuspid aortic valve or congenital syndromes like Williams syndrome or rheumatic heart disease. All right? But for all purposes, most times it's seen in an elderly patient unless they want to trick you up. Okay? That's aortic stenosis. Hi, Anton?
Yes, sir.
Sure.
I said for aortic stenosis that it's an injection systolic that happens at the left upper sternal edge, but
It primarily, Anton,
uh-huh.
see in the picture, right? So this is
Yeah.
one here is a right upper sternal border, that's the aortic area. Yeah? So that's where you're gonna look out for an aortic stenosis murmur or any aortic murmurs. However, the aortic stenosis in particular murmur can be heard in other areas of the chest wall as well. Okay? Because it could have a lot of when you're contracting against a narrow aortic valve, that blood could back up and cause a murmur on the left side because it can cause mitral regurgitation, etc. So that's why you can hear it at the apex as well, right? You could also hear it at the left upper sternal edge. In some cases, if you have pulmonary hypertension, that may lead to pulmonary stenosis and that may lead to pulmonary murmurs as well. Okay, but it's primarily heard at the right upper sternal.
Okay.
Sure. Thanks, Anton. Right? So the last thing about aortic stenosis that you guys need to know would be differentiating it from aortic sclerosis and then the treatment. So the treatment of aortic stenosis, guys, depends on whether the patient is symptomatic or whether the aortic stenosis is very severe in terms of measuring the orifice of the aortic valve. Okay, so if your patient is symptomatic, that is, the patient has these symptoms: syncope, angina, dyspnea, or heart failure symptoms, then the treatment is an urgent valve replacement. If the patient is asymptomatic, but they have very severe stenosis, that is, the valve area is less than 1 centimeter squared, you also do valve replacement. So urgent aortic valve replacement is done for symptomatic aortic stenosis and severe aortic stenosis, even if the patient is asymptomatic. If altogether the stenosis is not that severe and the patient is asymptomatic, we can simply observe them and make sure we follow them up in clinic. Okay, so our approach to valve replacement can be TAVR, that is transcatheter aortic valve repair, or we can also do STAVR, that is surgical aortic valve replacement. In Trinidad, many times we do surgical aortic valve replacement, but transcatheter is where you do percutaneous valve replacement, and that is primarily used in first world countries. Probably Jamaica might be doing that as well. All right. So for the treatment of aortic stenosis, urgent valve replacement in symptomatic patients and very severe disease. Okay. And then the last one for aortic stenosis and sclerosis is differentiating between stenosis and sclerosis. So stenosis is the bad one. Stenosis is where the patient is symptomatic with radiation to the carotids. They are both caused by the same thing: senile calcification mainly. The difference is sclerosis means hardening of the valve. That is only calcification, only hardening, but not necessarily narrowing of the valve leaflets. So that means stenosis is a narrowed valve leaflet, and that therefore would impede your outflow of blood. In sclerosis, it's just calcification. So what you can have is a murmur, but that murmur has no carotid radiation. You have a normal pulse and a normal S2 as compared to aortic stenosis where you have a single S2. So you will have a normal split S2 in aortic sclerosis. These patients are oftentimes also asymptomatic. All right. So guys, those 3 points are extremely, extremely high: aortic stenosis, aortic sclerosis, and HOFAM. Any questions or concerns? Is everything clear? Christina says clear, clear. Aliyah, Tahira, Shalene, Rico. Fantastic. So guys, every single bit of information I gave you all there on HOCAM is aortic stenosis and aortic sclerosis. Please know them well and know how to differentiate them. They come along. All right. So now we're going to go through the other murmurs and then we'll answer questions. And after that, we'll do ischemic heart disease. So the other valvular defects that you need to know would be aortic regurgitation as well, as we're on the aortic valve, and then we'll talk about the mitral ones, and we'll leave the tricuspid for last. Okay. So we're talking about aortic regurgitation here. All right. So if they are to bring aortic regurgitation, guys, you need to know a lot about the eponymous signs of aortic regurgitation, and that is a water hammer pulse, a Corrigan sign, Dimosset sign, Quincke sign, and Durozy sign. So what is each of these things? Well, Corrigan sign is where you have visible carotid pulsations. Perhaps I should type this in the chat. Right. So Corrigan sign, Corrigan is sorry, you see that's now visible carotid pulsations. That's Corrigan's, right? Dimosset's sign seen in aortic regurgitation is head bobbing with the heartbeat, right? Quincke sign is capillary pulsations at the peripheries when you do capillary refill, right? You'll feel capillary pulsations at the fingers, right? And then Durozy's sign is very interesting. It is also known as a double intermittent murmur. And what that is very interesting. Durozy's sign is where you have the patient, you place the stethoscope on the femoral pulse. And when you're going to have a systolic murmur and a diastolic murmur depending on your maneuvers. And so the first thing you can do is occlude proximally 2 centimeters proximally to the vessel, and you're going to get a systolic murmur. If you occlude 2 centimeters distally to the the vessel, you'll get a diastolic murmur. So for you to have what they call Drury sign, you need to have both murmurs positive. That's a positive Drury sign, and that's when you auscultate the femoral artery. Okay, so that is seen in aortic regurgitation. So those eponymous signs are critical to know. Those are distinction questions because students just bypass them. Now you know them, fantastic, learn them forever. Right? The other features, of course, of aortic regurgitation, we know would be our collapsing or water hammer
Sir?
pulse. Okay.
By chance, you can just repeat the measurements you were talking about just now with the 1 millimeter and the 2 millimeter.
Oh, no. That's up by the way, Alima. But I was saying if you occlude proximally, like 2 centimeters proximally, you occlude at the femoral artery. So you're placing a stethoscope on the femoral artery. Then you're going to place your fingers 2 centimeters proximally. That is more in the abdominal area. When you occlude there, you're going to get a systolic kind of murmur sound in the femoral vessel as you auscultate. However, if you occlude distally, that is lower down to the leg, you're going to get a diastolic murmur, and that is Jersey's sign, right? It's you don't have to be that specific. I was just explaining it. Just know it's called a double intermittent murmur, and know that it exists. This is low yield in terms of exams, but if it comes, it's a distinction question categorized as very difficult. Okay, so just know them, and you could explore them further. Clear, Alima? I don't know if she.
Thank you.
Alima? Okay, sure, no problem. Yeah, nice. Great. So the other things about aortic regurgitation, guys, would be the murmur itself. So aortic stenosis is a systolic murmur. However, aortic regurgitation is a diastolic murmur, and it's heard in the aortic area. But because it's an aortic murmur, it is also louder on expiration. That's your left-sided heart valves are louder on expiration. I was going to talk about the widened pulse pressure, contrasting that with the narrow pulse pressure of aortic stenosis. So for aortic regurgitation, if you see a very widened pulse pressure, that is a difference between your systolic and diastolic blood pressure of more than 100. So let's say the patient's blood pressure is 160 on 50 or whatever, some kind of weird number. They want you to think widened pulse pressure, and they want you to think aortic regurgitation if they bring a murmur as well, right? Good. So the causes of aortic regurgitation, it's good to understand. Infective endocarditis, of course, can cause any murmurs. Aortic dissection is high yield. And let's do a little bit of by the way here as I have it on the screen. So let's see. Tell me, what is the triad for Reiter syndrome, guys? What is Reiter syndrome? Okay, let's do the by the ways on the paint thing. All right. So the by the way here, very commonly tested is Reiter syndrome. Reiter syndrome. Let me undo that, and let me change this to black. So everything I say, guys, I will keep on repeating it whenever it comes up again. So you always see Reiter's when we do rheumatology, because Reiter syndrome is reactive arthritis. Okay, don't mind my handwriting. Listen to what I'm saying. It's just for illustration and for you to remember that Reiter syndrome has a classic triad. That triad of Reiter syndrome is can-C, can-P, can-chyma 3. So what can-C is the arthritis. It can't eat like this. So it can't have 3 hours of arthritis. Right? So there's a bit of implementation of Reiter syndrome. And because everything can control your arthritis, the most common cause of arthritis.
Dr. Knight, hello?
Hi, Nisha.
Yes, your mic gone muffled again. We can't really hear.
Hey, sorry.
Mm-hmm.
Hey, no, guys.
No, still muffled.
No, that's happening. Sorry about that. You'll get in here. Should I leave it here? Close my mouth. No, still. Hold on. Right. Yeah, not better. Can we please say yes? No. Okay, let me disconnect and reconnect again. Give me 1 second, guys, please.
If you have someone's phone number, you can actually track their digital I'm a good guy and I'm nice and I'm charming and I'm funny and you're missing out on a good
Hey, y'all hearing me? Y'all hearing me better now?
Yes, no.
Yeah? Okay, sorry about that, guys. I don't know what's happening. If y'all just let me know if it happens again, and I don't know why it's happening, right? So we could continue now. Hear me clearly? All right, cool. Right. Let me share back the screen here. Right, seeing the screen here again. Right, great. So that is our writer syndrome. Oh, I was telling you all that the most common cause of writer syndrome would be, this is chlamydia, right? Chlamydia infection, chlamydia urethritis, not gonorrhea, non-gonococcal urethritis. That is chlamydia. That's what that is there. Very terribly written. And also remember, oh my gosh. Also remember, not just chlamydia, you can also have reactive arthritis in patients with Campylobacter jejuni. Campylobacter jejuni is a gastrointestinal infection, and what does that usually cause? Apart from writer syndrome, which neurological condition is associated with Campylobacter jejuni, guys? Guillain-Barré syndrome, fantastic. And so that's what I mean by dynamic thinking with constant repetition. We see one thing, we lead into another thing and keep on revising that way, right? So that's how I teach. And I think it's pretty useful because everything that is by the way is actually a multiple choice question as well. All right, let me erase my thing here. Okay, so how did we even get here? I think we are talking about aortic regurgitation. Could be correct. I should be correct. Right, cool. Right, so we are speaking about writer syndrome as a cause of aortic regurgitation. And the other, by the way, that I want to say is in your MCQ stem, how do you know a patient has osteogenesis imperfecta? Anyone knows? What do they tell you? What clinical finding do they say in your MCQ stem to say this patient has brittle bone disease? That is osteogenesis imperfecta. That clinical finding is blue sclera. Okay, when the patient has blue sclera, fantastic, Alicia. That's osteogenesis imperfecta. Don't think about it, just circle the answer and move on to your next question. Great. So that's our aortic stenosis and aortic regurgitation. Now let's finish off with mitral murmurs, tricuspid and pulmonary murmurs in less than 10 minutes. All right? Good. So the other murmurs would be for your left-sided heart valve would be other left-sided valve, sorry. That is mitral murmurs. Now there are three that you need to know, and don't confuse them because that is what they like to do and trick you all, right? They like to bring, is it mitral regurg, is it mitral stenosis, or is it that third weird one, is it mitral valve prolapse? They are three completely different diseases, completely different pathologies, and therefore completely different murmurs in your question stem. So mitral regurgitation, the most popular murmur, it's the most common murmur for OSCE, we know is a pansystolic murmur at the apex radiating to the axilla. And because it's a left-sided heart valve, it would be louder on what? Inspiration or expiration? Any chat or unmute, anybody? Expiration, fantastic. So make sure you don't let the patient breathe in and hold, okay? Make sure they expire and hold when they're doing their maneuvers. I've seen students let them breathe in and hold, and they lost marks for that, okay? So it's pansystolic murmur at the apex, radiating to the axilla, loud on expiration with your patient in the left lateral position. It makes sense. You turn them to the left, the apex comes closer to the stethoscope, and therefore your murmur is louder. All right? So that's the features of the murmur to look out for. If it's described as that, that's mitral regurgitation. Don't think too hard about it. Once it radiates to the axilla, that's mitral regurg. Okay? Causes are many: infective endocarditis, rheumatic heart disease. When we reach the coronary artery disease, we're going to see papillary muscle rupture as one of those complications in a myocardial infarction. And remember that that could cause an acute mitral regurgitation. Okay, so when we reach IHD, we'll talk about that. Anything else I want to tell you here? Of course, the patient could have heart failure symptoms. I'm doing heart failure and coronary artery disease today, right? So it's valvular heart disease, coronary artery disease, and heart failure. So I'll talk a little bit about the murmurs in heart failure again when I do heart failure. I'll be more drawing to teach heart failure, right? But just know the murmur for mitral regurg, really, that's it. They hardly ask you to treat it, but remember all left-sided heart valve or valvular heart disease can lead to atrial fibrillation. So if the patient is in an AFib, we control the AFib. We give diuretics that could alleviate symptoms, and of course, a valve is defected, we want to repair or replace the valve, all right? But they don't really test treatment of these valvular diseases. we do AFib on Thursday, so don't study about how to control AFib and thing now. We'll talk about charts, fast scan, all of that. Right? So that's mitral regurgitation. What I want to point out here is that mitral valve prolapse can cause mitral valve regurgitation, but they are two separate entities. So if you see your murmur described as a mid-systolic click and late systolic murmur, that's mitral valve prolapse. If you see your murmur as pan-systolic at the apex radiating to the axilla, that is mitral regurg. Okay, so don't mix up the two. Mitral valve prolapse can cause a regurgitant murmur. All right. So that's one differentiation factor. Now, I want to ask you all about mitral stenosis. Shucks. I miss my distinction question. Shucks. I was going to ask you all which one of these murmurs presents or can present in an MCQ STEM with compressive symptoms. By compressive, I mean dysphagia, compressing the esophagus, dyspnea, compressing the trachea or bronchi, and hoarseness of voice, that's compressing the recurrent laryngeal nerve. You all could guess which which one of these would cause it. And if you read any guide, I think it's in the guide, right? All right, so okay, Alicia took an honest guess. She said MI. So it's mitral stenosis, right? So mitral stenosis, she changed it. She means MS. Okay, multiple sclerosis. Hey, what about multiple sclerosis? You all want to talk? Okay, we'll save that for you, right? So mitral stenosis, guys, is a very interesting murmur, and the most common cause of mitral stenosis is rheumatic fever. So rheumatic fever, remember rheumatic heart disease with the Jones criteria. I speak about that a little bit when we do our mock exams for the PEDS component. But rheumatic fever is the most common cause of mitral stenosis, right? A prosthetic mitral valve can become stenosed and cause mitral stenosis, and some patients can have congenital mitral stenosis, right? But what I want you all to know about mitral stenosis is the mitral valve is here, right? So this is your mitral valve. It's on the left side of the heart. It's an atrioventricular valve between the left atrium and the left ventricle. It's mitral. It has two cusps. It's also known as the bicuspid valve. And so the mitral valve, mitral stenosis, means it's a narrow valve here. If the valve is very narrow, then you have to pump against increased pressure, and that increases your left atrial pressure. And if it increases your left atrial pressure, then what is going to go? And so what happens in mitral stenosis is the left atrial. Oh my God, why is that happening? I don't know why that's happening. Sorry, guys. So awful. Oh my gosh. I might have to switch headphones in. Can you hear me, guys? I want to switch headphones. I'm feeling fine for me, actually.
It's still muffled up.
Am I back yet? Clear or muffled?
Where?
Clear. Okay. I think the headphones is probably malfunctioning a bit. Sorry, guys. I have one of those things with the mic in front of my mouth. The actual headphones thing. Thanks for the heads up, right? So I was speaking about mitral stenosis. I was telling you all that mitral stenosis. You hear me clearly, right? Okay, great. So mitral stenosis can lead to left atrial dilation. And so if you have an enlarged left atrium, that can actually compress your recurrent laryngeal nerve. It can compress your esophagus and lead to dysphagia, and it can compress your airways and lead to dyspnea. All right. Also for mitral stenosis, very interesting, it can present with hemoptysis. And why can it present with hemoptysis? Well, the same concept. Narrow mitral valve increases your left atrial pressure, and then what happens? The left atrial pressure backs up, and it increases your pulmonary capillary wedge pressure in your pulmonary veins. That leads to pulmonary hypertension. And so that pulmonary hypertension can present with hemoptysis and chronic bronchitis like picture. So two very key questions about mitral stenosis would be it can present with compressive symptoms like hoarseness of voice. So one of my questions I want to set when I start to set exams is a murmur in a patient with hoarseness of voice and hemoptysis. Which murmur is that? It's mitral stenosis, right? So it presents with compressive symptoms and pulmonary hypertension as well. Okay, so that is mitral stenosis. And the last thing about mitral stenosis I want you all to know would be these features. Just learn them off. It can occur, it can have a malar flush, a tapping and non-displaced apex beat, a right ventricular heave, and an opening snap. So these are the 4 features associated or 4 clinical signs that can be elicited in mitral stenosis. A malar flush, facial flushing, tapping and non-displaced apex beat, right ventricular heave, and an opening snap. The murmur of mitral stenosis, so mitral regurg is pansystolic. Mitral stenosis is a rumbling mid-diastolic murmur at the apex. That is, it's a left-sided heart valve, so it's heard loudest in expiration, of course. But the murmur for mitral stenosis is rumbling mid-diastolic murmur at the apex. What you can't see is this eponymous murmur called the Gram-Steele murmur as well. And anyone knows what other heart defect is really associated with a Gram-Steele murmur before I actually teach it? So a Gram-Steele murmur can be seen in your pulmonary regurg as well, right? So that's Gram-Steele murmur. But it can be seen in mitral stenosis. And the last teaching point for mitral stenosis would be it's the left-sided atrium valve. You could have atrial fibrillation. And remember, guys, atrial fibrillation, that is valvular in nature, what do we anticoagulate with? Warfarin, right? So valvular AFib is the one form of AFib where the first line of anticoagulation is not a DOAC, it is actually warfarin. So valvular AFib, we anticoagulate not with rivaroxaban or apixaban or any of those things. We anticoagulate valvular AFib with warfarin. So my question for you is, what is our target INR for a patient we're anticoagulating with with warfarin who has mitral stenosis? So Julian says 2 to 3. Do we agree with Julian? All right. So we're targeting an INR of 2.5 to 3.5 for mitral valve AFib, mitral due to mitral disease, but 2 to 3 due to aortic disease. Okay, so our INR targets are different. It is a very niche and intricate topic. And when we do warfarin for hematology, I'll go through each of them. But for mitral disease, we're targeting 2.5 to 3.5. For aortic is 2 to 3. For AFib in general, without valvular heart disease, it's 2 to 3 as well. But if it's due to mitral valve, guys, 2.5 to 3.5. If it is PE and DVT, it's also 2 to 3. But if the patient has recurrent PE and DVT, then we up our INR to, again, 2.5 to 3.5. 2.5 to 3.5. Okay, so your target INRs are tested in your exams, all right? But for mitral, that's a very important one. You up the INR target value. It's 2.5 to 3.5. All right, good. So that's mitral stenosis. And mitral valve prolapse is the most common valvular abnormality overall, actually. I saw that in one of those books I was reading. I didn't know that, so I just included it here. I think it's the Oxford had this, right? What I want you to know about mitral valve prolapse is simply the murmur. It's associated, with Marfan's, Turner's, all these congenital conditions, but know the murmur of mitral valve prolapse is a mid-systolic click followed by a late systolic murmur. Okay, so once you see mid-systolic click, late systolic murmur, that is mitral valve prolapse. That is not regurg, and stenosis. We already went through them. All right. Any questions on the mitral murmurs? We're going to do tricuspid and pulmonary in 2 minutes. Are we clear on the mitral regurg, stenosis, and MVP, mitral valve prolapse? Yeah? No questions or concerns, right? Crystal clear. So everything I say, everything I teach, guys, can come, okay? Fantastic. Good. And so to close, we'll do the right-sided heart valves. Let me just accept 2 people here. Brittany keeps getting logged out. Not too sure why. Okay. Right. And to close off valvular heart disease, we'll talk about the right-sided heart valves. What I want you all to know would be the most important one out of the right side. I saw them bring for both June and December is that of tricuspid regurgitation in a very roundabout kind of way, but easy to figure out once you know it. Okay, so tricuspid regurgitation murmur is a pansystolic murmur at the left lower sternal edge. What helps differentiate it from VSD is that it can be loud on inspiration, because remember your ventricular septal defect is where you have your pansystolic at the left lower sternal edge as well, right? Well, how they brought tricuspid regurgitation for MBBS was a patient had, let me get this precise. I think I have a question in it, so I'm actually telling only the answer here. Wherever. The patient had hepatic congestion with a distended jugular vein, and they asked, what is the underlying pathology? And all the options are wrong. It was like, or what do you expect to hear? I think it was pericardial rub versus like a split S2 versus this murmur. So just remember that tricuspid regurgitation can present with right-sided heart failure. Why? Come on, guys, thing real easy. It's a right-sided heart valve, okay? So it's a right-sided heart valve. This is a tricuspid valve. If you have regurgitant blood, that blood is going to go back up from the right ventricle through the tricuspid into the right atrium. Then it's going to shoot up through your SVC and shoot down through your IVC. And therefore, you have right-sided heart failure symptoms or hepatic congestion with distended JVP. I go through it properly when we do heart failure. But I just wanted you all to know, if you see that picture, think about tricuspid. Oh my God, I don't know what I did there. Okay, if you see that picture, think about tricuspid regurgitation, right? Also, remember, it's a right-sided heart valve. What leads to the right side of the heart? Veins. So if you have IV drug users, infective endocarditis. So in IV drug users, the tricuspid valve is the most commonly affected valve, okay? And that would lead to tricuspid regurgitation as well. So tricuspid regurg can be seen in IV drug users, infective endocarditis as well. And I just included a couple other things for you all to read up about Epstein anomaly and all those things. Epstein anomaly is when the tricuspid valves are lower down in the ventricle. It's very strange. All right, that's a congenital heart defect. Low yield, but when you're reading, so when you all are reading through the guide, anything that is unfamiliar, just Google it a little bit, right? If I didn't mention it, it's because it's extremely low yield. Okay? Somebody's messaging me. Okay, cool. Somebody's trying to join my class, wants to sign up for the class during the class. Interesting. All right, cool. So tricuspid regurg, that's that. Right-sided heart failure, pansystolic murmur, the left lower sternal edge, louder on inspiration. It's a right-sided heart valve, so it's louder on inspiration. Next, we have tricuspid stenosis, lower yield, seen in rheumatic fever, infective endocarditis. Again, a narrow tricuspid valve, blood backs up into the right atrium, and you have right-sided heart failure, presentation, pulmonary, hepatic congestion, etc. Very simple. But what is important to note, guys, when I do JVP waveform, is the manifestation is very commonly tested. Tricuspid stenosis on a JVP waveform. Tricuspid stenosis for a JVP wave presents as giant A waves and a slow Y descent. Okay, so that's tricuspid stenosis, whereas tricuspid regurg is a giant V wave and a prominent Y descent. All right, so learn about JVP waveforms. I'll be sending videos on YouTube after we finish to learn a little bit about JVP waveform, because I might not actually teach it because it's low yield, but it is tested, right, a JVP waveform, so you'll understand what conditions, how they present on a JVP waveform. It's basically like a ECG. So for tricuspid stenosis, it's giant A waves and a slow Y descent. Tricuspid regurg, remember the murmur, pansystolic, louder on inspiration at the left lower sternal edge, seen in IV drug users, and it could lead to pulmonary, it can be seen in patients with pulmonary hypertension, sorry. Let me talk about that a little bit. So if you have a mitral stenosis type picture, okay? Mitral stenosis or whatever, your left atrial pressure increases and you have pulmonary vein pressure, increased pressure, you have pulmonary hypertension that then backs up to the right side of the heart. Okay, so if you have backing up of that pressure to the right side of the heart, that too can lead to valvular heart disease or valvular heart defects, right? So that's pulmonary hypertension stemming from left-sided heart disease, leading to tricuspid defects, right? And the last thing is pulmonary stenosis and regurg. I have a very short thing here. Remember, pulmonary stenosis is PEDS, it's congenital. Pulmonary stenosis can be seen in internals, tetralogy of Fallot, Noonan-Williams syndrome. All of that is here. It's an ejection systolic murmur as well, so it's a differential for aortic stenosis, HOOCM, and aortic sclerosis. But it's not particularly high yield. And then pulmonary regurg. Any condition that causes pulmonary hypertension can cause blood to come back through, of course, the pulmonary valve, and therefore you have pulmonary regurgitation. And we just said, along with mitral stenosis, Gram-Steele murmur can be seen in pulmonary regurgitation as well. Great, that's valvular heart disease. Any questions or concerns on valvular heart disease, guys? Are we clear on all of the valvular heart diseases, the HOOCM, how to differentiate between aortic stenosis, aortic sclerosis, MVP, MR, and MS for future references? We know a little bit about the AFib INR for mechanical valves, that is a mechanical mitral valve. We did a little bit about Reiter syndrome as we went along and osteogenesis imperfecta, etc. Any questions on anything we have done so far, guys?
Just repeat the Reiter syndrome.
Reiter syndrome, triad is urethritis, conjunctivitis, and arthritis. That is can't see, can't flee, can't climb a tree. It's associated with chlamydia. Chlamydia is the most common cause. Chlamydia urethritis is the most common cause, but it can also be seen in patients who have Campylobacter jejuni. That causes dysentery, that is a bloody diarrhea, to be specific. Campylobacter jejuni also causes Guillain-Barré syndrome.
Okay, thank you.
Hey, Janine? Cool. Sure. No probs. All right. So now, last but not least, is our murmur characteristics. What makes this innocent? What makes this pathological? Okay, so high yield point. Pansystolic murmur is pathological. I think I saw most people choose pansystolic, right? A mid-systolic murmur is what is more suggestive of innocent. Okay, so these are your findings. Just learn this off. I'll do the question and point out the high yield points. Go through the guide and just learn of these that I have here, okay, for the difference between innocent murmur and pathologic. It comes for PEDS all the time. So most of you all would have gotten that wrong. So we'll go through it, right? So once no questions, let's answer our question. Okay, good. So now that we've taught, I would like everyone to rapid fire answer number 1. What you all think is, okay, what is the diagnosis for this patient with number 1? Because that's another way of asking this question in MCQ form. What's his most likely diagnosis? Yes, meaning aortic stenosis. I like how someone said stenosis, right? Because we don't want to confuse it with sclerosis. That's fantastic. So it's aortic stenosis. Fantastic, 100%. Why is it aortic stenosis? It's an ejection systolic murmur at the left sternal edge, also the right upper sternal border, radiating to the carotids. We also see that's an elderly patient presenting with syncope, angina, dyspnea, dizziness makes sense. And we see that his blood pressure is a narrow pulse pressure. It's less than 25. 139 minus 122 is 17. So that is all clinically in finding with aortic stenosis. We also do an ECG and it shows left axis deviation, which can be an ECG finding of aortic stenosis. And cardiac enzymes being normal rules out a myocardial infarction. So this is indeed aortic stenosis. It's symptomatic. So what's your answer? I want 20, 100 million answers to make sure everyone is on the same point. 100% correct. We want to do for this guy an aortic valve replacement urgently, because the 5-year survival rate, or I shouldn't even say 5-year, these patients usually succumb to cardiac death or death due to cardiac reasons within 1 to 2 years if they don't have a valve repair. All right, so fantastic, excellent. So that's aortic stenosis, and we know the murmur. If they had said it was exacerbated by Valsalva, we thinking Hookham and so on. All right, so now number two, what is this patient's diagnosis? Fantastic, right? So this patient has Hookham. Excellent. So we see that because it's a previously fit 23-year-old. He playing football, but he taking far longer to recover. He also has some dyspnea, and he has this angina during vigorous activity. All of these things in a young male, you're thinking Hookham. All right. ECG shows left axis deviation and left ventricular hypertrophy, and then the echo gives off the answer to say thickening of the interventricular septum, which is Hookham, right? And he also has a family history of sudden death below the age of 50. Remember, it's autosomal dominant. And this patient would present with a murmur that is exacerbated by Valsalva. So based on our teaching, what is the correct answer here? I think we had a couple ones, but let's see, everyone on the same page. Wait. Did I see a B? So here, there you are. You're sure, right? You need me to explain it again, or you're sure? You'll say D because everybody's saying D. Now I want to make sure each and every one, don't leave anybody behind. Okay, good. All right, great. Yeah, so we have features of ejection systolic at the left edge, murmur with Valsalva, E-fib, and a double apex beat. A mid-diastolic murmur, the apex can be seen in which heart defect? Which valvular heart disease? Fantastic, mitral stenosis, right? And we went through a whole lot of mitral stenosis before. Great. And then number 3, which of the following features is most likely in keeping with that of an innocent murmur? Well, I just gave you all the answer, right? Great. So pansystolic, pathologic. I want you all to know that. So it's mid-systolic, right? So mid-systolic is innocent. Pansystolic, pathologic, grades more than 3 out of 6 is pathologic. Harsh and natia is pathologic. Radiation is also pathologic. As per our document here, we have a nice little summary of them here, right? So pathologic is grade 3 and above, pansystolic, radiation, harsh and natia, additional heart songs, heave trills, whereas innocent is mid-systolic, grade 2 or less, minimal radiation. And then this thing here about positional variation in intensity, I want you all to write that down. That's how the question came for MBBS. So positional variation makes it more likely to be innocent, okay? So that's how they brought the MCQ for MBBS. Good, so we all got that correct. Great, is everybody clear on valvular heart disease? That completes our teaching on valvular heart disease. I don't think there's anything that they will test on valvular heart disease outside of what we taught. I think that was extremely comprehensive. Valvular heart disease is going to come for your exam, okay? So note well. Fantastic, everyone, lovely. So we'll take a 5-minute break, class. So my classes, let me just run this joke with you, right? Last year when I did this thing, classes started 6 and used to finish like 9:30 and thing, right? Because I used to try and do everything in one class. That's why now I do Monday and Thursday for one topic. And to supplement what we learned, we're going to do homework. I'll show you an example of the homework. When you do the homework, I'm not giving you all the answers until you send me the homework, and then I send you the answers. The homework is 20 MCQs or so on what we would have covered, and it helps tie in everything. Then I'm going to give you an answer sheet on that, again, re-explains what you went through to class. So it then further consolidates all of your information. So it's going to be fantastic. Once you do the homework, it will tie in everything. Any questions you have after, you could always ask me, right? But before, classes used to finish 9:30 and thing because I used to try and do everything in one now. But now we're doing it half cardio now and then half on Tuesday. So we're not going till 9, but we might probably go till like 7:30. And I try not to ever go beyond 7:30 for these classes. So we will take a break. Then we're going to do the second most commonly tested thing, which is coronary artery disease, and then heart failure. There's a few things that they like to test, so that shouldn't take too long to teach. All right, everybody good? Clear? Following? Yeah? No? Yes? Clear? Okay, great. So we will resume at 7:27 exactly. We take 7 minutes break. All right? So 7:27, guys. Thank you, everyone. 7:27. You all are going fantastic. Everybody answering. I love it. 7:27 we'll resume. Thanks. Hey, hi. You all hearing me?
Yes, Doc.
Hi, thank you. All right. Um, so let me see. I just point out random. I'll call out one name from each campus. Leah Ramlagan. That's how I pronounce your name, right? Guys, if I butcher your names, please correct me.
Hi,
Leah?
Doctor. Yes.
Hi, how is class going?
Really good so far, Doc.
Able to follow along?
Yes.
Okay, great. I know I teach very fast, so that's why I tell you all to always stop me, right? I try to get to as much info as possible. Let's see. We have another Leah Adams. Okay, Phil.
Hi, good night.
Hey, Leah, how we find classes?
It's going good so far. I guess it's just after to go back and consolidate, but it's going good so far.
Okay, sure. Yeah, so everything we do, of course, it will be the first time for some new teachings and new things to learn. That's why I tell y'all, have your notes. We have the guide there as well. That'll be pretty useful. And then when we do the homework now, everything just kind of comes together because give you all the information. I try to make it simple. If you don't understand it, ask me. I make it clear as possible, and you just consolidate. That's fantastic, Alia. Abigail Smith, Mona. Abigail, you there?
Yes, Doc, I'm here. It's going good so far.
Yeah, sure. I know you all get fantastic teachings at Mona, so I didn't bother to offer my course before. How you think? Is on the Mona level or I lagging behind? Tell me.
Yes, Doc, you're on par.
All right, thanks. Let me see who we have from SCMR here. I'm just going down the list. So the first SCMR I see is Brian. Brian Higgs.
Good
Brian, you
evening.
there?
Yep,
Evening, bro. What's up? How things? You were not in my demo.
I wasn't. Yeah, I was.
You were there. Okay, so
Yeah, it's pretty.
how you find?
It's pretty good, pretty informative. Really enjoying it.
All right, nice. Thanks, man. Yeah. So those of you who weren't in my demo, I usually have the demo to make sure that students, I don't take nobody money and make you all sign up and it can't learn this way, right? Because I teach in a very kind of different way, roundabout kind of way, always straying from the point and then coming back. So if you were not in my demo first time listening to me teach anything, and by the way, guys, anything that I can improve on, you'll let me know after the class and private message me. But for those who are completely unfamiliar with how I teach, it takes some getting used to. But I think once we push on through by the third and fourth class, you'll usually kind of keep up and kind of could predict how I'm about to do a topic. All right. So thanks everyone for the feedback. Wonderful. We will resume now with some questions. We're going to be doing coronary artery disease, critical topic. Every single thing that I say in coronary artery disease while teaching it is a testing point. All right, so pay strict attention. So let's go. We're going to answer 3 questions here. Good. Nice. All right, so answers to number 4, please. Answers to number 4 in the chat, please. Thank you. Okay, great. What is the location of this patient's myocardial infarction? Which part of the heart is affected and which artery is occluded? That's a question. and which arteries are occluded. So that's another thing you'll need to know. Good. Number five. Answers to number 5 in the chat, please.
Sneezing is an involuntary expiration.
Very good. Thanks for the answers to number 5. And last question before we teach number 6. Answers to number 6 in the chat, please. Answers to number 6 in the chat. No more answers to this one. That's my answer. Ahí escucharon que la cita también, la cita también, porque es ahí sobre come back there, Christina.
Yeah.
Yeah. Yeah, I don't know what I do. Sorry, guys, I'm not sure why that is happening, but I realize if I turn off and on, it seems that once I put it back on, it seems that it kind of rectifies. You'll hear me clearly, right? Okay, great. Thanks, Christina. Cool. So yeah, number 6 had these mixed answers. I was saying I like questions like that when you all don't know everything and we have something to actually teach because they're real bright. So difficult to teach very bright people, but at the same time it should be easy. It's a very funny concept. All right, guys, thanks for answering. Wonderful. I got a lot of participation there. And we're going to start off teaching ischemic heart disease, the second most commonly tested topic in terms of overall testing. The test varies. Literally, I have constructed myself about 60 questions, and I just do these things for fun, right? On just angina, right? Not even coronary artery disease, just angina, all right? So it's vast, but in the teaching, it should cover most aspects of how they bring questions, okay? See in the guide screen, guys? Cool. Right. So ischemic heart disease. So the first thing I want you all to know is how are we going to categorize ischemic heart disease as cardiologists do? And that would be in terms of stable coronary syndrome and acute coronary syndrome. And notice we have INOCA and MINOCA. INOCA and MINOCA is ischemia with no obstructive coronary artery disease, and MINOCA is myocardial infarction with no obstructive coronary artery disease. And so that means INOCA and MINOCA is not what we're going to talk about. We are going to be talking about obstructive coronary artery disease, which is by far more common than no obstruction leading to ischemia and MIs. However, I will speak about type 2 MIs at the end of our teaching, right? But for all intents and purposes, we're focusing on obstructive coronary artery disease. And so our primary focus would be stable obstructive coronary artery disease, then acute coronary syndrome, which would be three things: unstable angina, NSTEMI, and STEMI. All right? So I didn't have any questions on angina here tonight, but this is why the homework is important, because I do have 2 questions on angina in the homework, and I want you all to answer it to bring home the angina teachings, okay? So pay attention. All right, guys, let's go. So when we talking about angina, I'm not going to talk about ischemic heart disease just yet. I'm talking about angina alone. We have 3 that we need to know. That's stable, unstable, and Prinzmetal, and how to differentiate them. MCQ question: patient come with chest pain. Is it stable? Is it unstable? Is it Prinzmetal angina? Right? So stable angina means stable. That is chest pain only with exertion, and it is relieved by rest. So the patient is otherwise stable. Unstable angina is chest pain with exertion that is not relieved by rest, or new onset chest pain, or chest pain at rest. All right, so that's unstable angina. And Prinzmetal angina is due to coronary artery vasospasm. So for your stable angina and your unstable angina, this is just ischemic chest pain. That is myocardial ischemia. So angina refers to myocardial ischemia, and that is important because it's not myocardial infarction. The other type, Prinzmetal angina, is also known as, and I want you to write it down, variant angina, V-A-R-I-A-N-T. That's how it came for MBBS as an option, okay? So Prinzmetal is variant angina, and that is usually due to coronary artery vasospasm. The caveat here and the high yield point is that for Prinzmetal angina, unlike stable and unstable, where we are going to target multidynamic aspects, including the atherosclerosis, the hypertension, etc. For Prinzmetal angina, our treatment of choice is simply calcium channel blockers to cause vasodilation. It's due to vasospasm, so with a CCB, we'll cause vasodilation. So that's how we treat Prinzmetal and variant angina. It's an MCQ point that comes very often, and its presentation would be just these random bouts of chest pain unrelated to exercise or rest. Okay? So now we're going to talk about coronary artery disease and ischemic heart disease, starting with stable angina. All right? So stable angina, we said, is chest pain on exertion relieved by rest. So your patient is going to come, doc, I'm having this chest pain every time I exercise, and so on. Usually, the patient would have risk factors for atherosclerosis. All right? And so the patient might have hypertension, diabetes, dyslipidemia, high cholesterol, etc. And you're thinking, all right, this sounds very much like coronary artery disease. But any patient who presents to the emergency department with chest pain, our first thing we do, obviously, is an electrocardiogram. That is a ECG. The ECG for stable angina is usually normal, unless the patient is having a bout of ischemia. Maybe they have walked up long flights of steps and now it's increased the demand of oxygen. Most cases of stable angina show a normal ECG, and those are cases where they have exertion or where they exert themselves, you have ischemic changes, right? And the ischemic changes on an ECG are ST depressions and T-wave inversions most commonly. When you do an ECG, any patient with chest pain, we're going to work them up completely. We're going to do CBC, RFT, LFT, HbA1c, blah, blah, blah. Most importantly, we're going to do cardiac enzymes. So our cardiac enzymes, angina, in all types of angina, angina refers to myocardial ischemia. Therefore, the heart muscle does not break down. It is not dead. There is no infarction. Therefore, there is no release of troponin. Stable angina, unstable angina, both of them, we have normal cardiac enzymes. When we're talking about stable angina, again, all cardiac pathology, the 3 investigations are ECG, echo, chest x-ray. And we also want our bloods. But the echo and the chest x-ray in stable angina is usually normal. Okay? So we have the patient, he's chest pain with exertion that is relieved by rest. We're saying, all right, he's thinking stable angina. we can't just send that guy home with no follow-up. What we want to arrange for when a patient presents with stable angina is stress testing. So what is this thing about stress testing? Stress testing comes in two forms. That is an exercise stress test and a chemical stress test. The theory behind it is, or the theory behind all ischemic heart disease is supply and demand of oxygen. Okay, so let's see if we could kind of thing this thing here and see if we could just kind of make everything very easy. We have this block here. We have this next block here. We put our next block here. And we probably put our next block here. And we probably put our next block here as well. Right? And we will do this here as our normal blood vessel. Right? So this is a normal blood vessel. And the blood flowing, the blood flowing, the blood flowing. So these are our coronary arteries, right? These are our coronary arteries. And this here is going to represent our cardiac muscle. Right. And red is representing blood flow, and yellow would represent a plaque. So the first one is normal. That's a normal patient. We have normal perfusion, and therefore we have normal blood supply and normal oxygenation of the cardiac muscle, right? This here is going to be our patient with a plaque. Okay? So, oh, I said I was doing the plaque in yellow. Let me do the plaque in yellow. This is our patient with a plaque. This is our patient with a plaque, and our patient with a plaque, and our patient with a plaque. All right? So this first one, this patient has a plaque, and the plaque is stable. It's stable. So black means it is stable. It has not ruptured. It is stable, and therefore there is still space for blood to flow. And therefore, in this patient, they will have ischemia. So we're going to represent ischemia with a light color. So blue is ischemia, right? Just a little bit of decreased oxygenation. However, the plaque has not ruptured. The patient has ischemia, but because the plaque has not ruptured and the lumen is not narrowed as much, this patient only has chest pain when the demand of oxygen increases and the supply is reduced because of this narrowing. So in stable angina, this is stable angina, we have no plaque rupture, our plaque is stable, and so the patient only has ischemia on chest pain because there's enough blood flow at rest to meet the demand, but when they exercise, the demand greatly outweighs the supply, and we don't have that supply, we have ischemic changes. So that's stable angina. This one here is unstable angina. So what happens in unstable angina is that this plaque is actually a little bit bigger, right? But still, in unstable angina, we have no plaque rupture just yet. However, in unstable angina, the lumen is narrower. Okay, so the lumen is so narrow that the myocardial ischemia is very, very bad. And so these patients with unstable angina, though their plaque is not ruptured, their ischemia is very severe because the vessel is extremely narrow. All right, and so this is called subendocardial ischemia, right? So don't mind my handwriting, listen to my voice. Subendocardial ischemia, and that is seen in unstable angina. Now let's contrast that with these two bad boys below. Our plaque, some reason, wake up one morning and this plaque ruptures. This plaque rupture now leads to this platelet aggregation, and that is thrombus formation. So you have a thrombus now being formed because of a plaque rupture. That thrombus formation and plaque rupture is now going to lead to an extremely narrow lumen that leads to infarction. Okay, and this here is going to be, because we still have a little bit of blood flow, this is going to be our end STEMI here. All right, so our end STEMI is due to plaque rupture, and yes, the lumen is that narrow that it causes muscle tissue death, and it causes a subendocardial infarction. So unstable angina is subendocardial ischemia, end STEMI is subendocardial infarction. And now for the last big bad boy, we have this one where the plaque ruptures completely. Should do this in yellow. What did I use? Purple. And then When that plaque ruptures completely, the thrombus formation completely occludes the vessel. And that's our big bad boy. That's our STEMI. Okay, so that is our big fat bad boy, because in our STEMI, we now have complete occlusion of the vessel, meaning all the oxygen is gone. And so we have for our STEMI, we have what we call a transmural infarction. Okay? Transmural infarction. So for stable angina, which is what we are talking about, for stable angina, we want to now put the patient's heart under stress, because once we increase the demand, then we will be able to tell if the supply is sufficient to meet it, and we can determine and diagnose if it is because of stable angina or obstructive disease that this patient is having their chest pain. So for stable angina, we'll have to do stress testing. All right? So the forms of stress testing for stable angina, right? There's exercise stress test and stress test. So the exercise is how patient transferring.
Again. Again, where?
Now, I don't know if it's when I switch the screen that's probably happening. You'll hear me clearly? Yeah, probably when I switch the screen that's happening. I don't know why. Damn. All right, sorry. So stress testing, all right. Pay attention here, because this is the how they bring stable angina, the stress testing, and then the management a little bit, right? So stress testing can come in the form of exercise stress test and chemical stress test. So in a patient who is fit to exercise, we will do our exercise stress test. So how it goes, your patient they thinking had stable angina, you send them to the cath lab or cardiac lab or whatever, and they say, all right, doctor, here's the stress testing. You firstly need to get a baseline ECG. All right. So when you get that baseline ECG, you will see, all right, this patient should have no ischemic changes at rest. Right. That's a baseline ECG. Then you let them run on a treadmill and they exercise very long. This exercise should precipitate in a patient with stable coronary artery disease, should mean that the demand of the heart increases, and it should precipitate ischemic changes. Now, how are we going to tell that this patient has ischemia based on our stress test? There are three things that we must know. One is our ECG readings, two is our MPI, and three is our echo. MPI is myocardial perfusion imaging. I think I have an image down here, because some of you might be unfamiliar because we don't really have it here. I haven't seen it in public system. But it's myocardial perfusion scintigraphy. So this is normal. However, in areas of reduced perfusion, as down below, we see an reduced uptake of our nuclear test, right? So this is MPI. So when you do the stress test, patient runs on the treadmill, they get a heart rate above like 200 or whatever, depending on the patient's age and so on. You're looking for ischemic changes on the ECG, that is ST depressions and T-wave inversions. You're looking for poor areas of perfusion on an MPI and wall motion abnormalities on an echocardiogram. So those three signs mean you have a positive exercise stress test. Once you have a positive stress test, I will tell you the next step, which is a coronary angiogram. But before I go on, does anyone know, most of the times we're going to do ECG. Does anyone know when we, after our stress test, when we would prefer to use an MPI or echocardiogram? Because we have them run on the treadmill, and usually we just connect the ECG, see the ischemic changes and so on. But what about if we thinking we should use a myocardial perfusion or echocardiogram? So in cases where our baseline ECG is abnormal, so remember we had a baseline first. So if our baseline ECG showing some sort of left bundle branch block or some sort of Q waves, then our exercise stress test should show, and we don't have any normal baseline ECG. So our exercise stress test would show ischemic changes, but it'll be difficult to tell on the ECG. So if a patient's baseline ECG is abnormal, then after we do our stress test, we would opt for a myocardial perfusion imaging or echocardiogram as a better means of assessing ischemia. Okay? So that's when you prefer MPR and echo over ECG to test the exercise stress test. Right? Is that concept clear, guys? Great. Right. So now, what about chemical stress testing? Well, if the patient is unfit for exercise, then we can do chemical stress testing. And what chemical stress testing is the same thing like exercise. You're going to let me teach this. Let's go back. Okay, so you're either going to try to increase the demand or reduce the supply. So the chemical stress test, the chemicals that we use, you see I group it here, dobutamine is one chemical we can use, or we can use dipyridamole or adenosine. Does anyone know why I group them together like this? I said we can either increase the demand or reduce the supply to determine our ischemic changes. And so let's do this thing here. So the butamine, I want you to write that down. The butamine would increase the demand. Why would it increase the demand? Dobutamine would cause a tachycardia. Your heart beats faster, your heart muscle has to contract harder, and therefore you need more oxygen. So dobutamine would increase the demand, and therefore if the demand is increased but you don't have enough supply, then we will see ischemic changes. And so when we do a dobutamine stress test, our imaging preference of choice would be our echocardiogram, because dobutamine increases the demand of oxygen, and so you will have wall abnormalities as your signs of ischemia. However, dipyridamole, I don't know, I think I spelled that correct there. Dipyridamole and adenosine, what they do is they reduce the supply of oxygen. And so, because they reduce the supply, when we do dipyridamole or adenosine testing, we have to do a MPI, myocardial perfusion imaging, because we will see the reduced areas of perfusion on the MPI. And just as a teaching point here, why does dipyridamole why does dipyridamole right? You all hearing me, right?
Yes,
Cool.
Doc.
Yeah. So dipyridamole and adenosine works I'll just teaching this quickly, just for your knowledge. So you can justify why you want to do a MPI for dipyridamole and so on. For dipyridamole and adenosine, right? So let's say we have two vessels here. This is our coronary arteries here, right? And this is our heart muscle. So this is coronary artery 1, and this is coronary artery 2. Our coronary artery 1 is normal. Our coronary artery 2 has, has our plaque, right? So our coronary artery 2 has our plaque. What dipyridamole and adenosine do, they actually cause vasodilation, but they only vasodilate the normal blood vessel. So when they do, hi.
We're not seeing a screen.
Okay. Apologies. Seeing it now?
Yeah.
Right. Yeah. So talking about dipyridamole and adenosine, right? What they do is they cause vasodilation. So saying coronary artery 1 here is normal, with a plaque, and coronary artery 2 has our plaque. This is a patient with stable angina, so our plaque is stable, it's not rupture, right? When you give dipyridamole and adenosine, they're going to
Hello?
be. Hi.
Hi, you're muffled again.
You all hear me clearly again?
Yes, much better.
Yeah, I think it's when I switch the screen. I'll have to look into that. Right. So, quick teaching point. Dipyridamole, adenosine, why it reduces supply is because it will vasodilate the normal coronary artery, but it would not vasodilate the affected or diseased coronary artery. And so what you have happening is your blood flow is going to go from the area to low pressure, from higher pressure to lower pressure. So all of the blood is actually going to go through the normal vessel. That is what we call coronary steal syndrome. So dipyridamole and adenosine cause coronary steal syndrome by vasodilating the normal blood vessel, and therefore all of the blood goes towards the normal side, but it reduces the blood supply to the diseased vessel, and so you have ischemic changes there, right? And so because of that, we need to do our myocardial perfusion imaging if we give a patient dipyridamole or adenosine for chemical stress test. Okay, I'm just going to switch screen, take off the mic and put it back on so we could try and avoid this muffling thing and see if it works. Okay.
Hey, quick question. Sati, can you hear me?
Okay, you all hearing me again clearly? Hello? Clear, right? Not muffled. Okay, sure.
Hey, I have a
I think it's
question.
sure. Who's that? Ivana? Hey, what's up?
Yeah, so you just to reiterate that point that you were trying to bring across the coronary steal syndrome. You said that it goes to the normal coronary artery, but not the affected or diseased coronary
Yeah.
artery.
So dipyridamole and adenosine, yeah, would vasodilate the normal artery, but because the artery is diseased, the coronary artery that has the plaque in it wouldn't vasodilate, and so your narrow lumen stays narrow, and instead of the blood going to that area of high pressure because you have a basically increased vascular resistance in a narrower lumen, it goes all the way to the vasodilated vessels and therefore reduces the supply.
Okay. Okay, I think.
Understood?
Yeah. So where you would see ischemic changes on the disease side.
Yeah. So the myocardial perfusion imaging will show the ischemic changes wherever it's diseased, right? So you could kind of tell, right? But that now brings us, Ivana and everyone, to what we doing next, because we just seeing ischemic changes. But what do we do if we have a positive stress test? So our next step after a positive stress test is a coronary angiogram, angiography, not angioplasty. Angiography is graph is image, right? Angioplasty is stent with balloon, okay? So coronary angiography, where we visualize the coronary arteries. So a positive stress test must be followed by a coronary angiogram. And what this will do is this will determine our need to revascularize a patient with stable coronary artery disease. So when we do our coronary angiogram, after we have our positive stress test, we can discover one of two things. We can decide one of two things. Is this patient a candidate for PCI, which is coronary angioplasty with stent, or are they a candidate for CABG? And what is the difference? In patients with single vessel disease, we are going to opt for PCI, coronary angioplasty with stenting. However, if a patient has left main stem disease or triple vessel disease, then we are going to opt for CABG. Okay, so our angiogram is going to tell us, hey, does this patient have triple vessel disease, left circumflex, left coronary, left LAD, left circumflex, and right coronary? Does this patient have left main stem disease? Then we're going to do a CABG. Or does this patient just have a simple single vessel disease, right? And in that case, we'll do a PCI. So stress testing followed by coronary angiogram to determine the need for revascularization. Okay, And the last teaching point about stable angina is how do we treat stable angina? Well, if a patient comes and is thinking stable angina, and you do a stress testing, and in the interim they're waiting for revascularization possibly, what do? We want to start them, of course, on lifestyle modification, diet, exercise, simple things like that, right? These patients, we want to prevent thrombus propagation. So you can write that down next to low-dose aspirin. We're going to give them single antiplatelet therapy for stable angina with low-dose aspirin. That is to prevent the thrombus propagation in the event of a ruptured plaque. Okay, so low-dose aspirin is our antiplatelet therapy. These patients may also, and most of them, we prescribe a beta blocker once no contraindications. The beta blocker would reduce the heart rate, right? It acts on the beta 1 receptors in the heart to slow down your heart rate. When you slow down your heart rate, you reduce the myocardial demand for oxygen. And therefore, when you put them on a beta blocker, this should altogether quell their symptoms as well. Remember, contraindications to beta blocker use, asthma, COPD, etc., especially our non-cardioselective, because our respiratory tract has beta 2 receptors, and if you block it, you can have bronchoconstriction, right? So that's just a reminder, by the way. Also, we can use a calcium channel blocker for stable angina to cause vasodilation of the vessel. But a high yield point is we do not use a beta blocker with a non-dihydropyridine calcium channel blocker. Non-dihydropyridine is verapamil and diltiazem. If we use a beta blocker with a non-dihydropyridine calcium channel blocker, what's going to happen? Our non-dihydropyridine is not does not just work on the peripheral vasculature, it also works on the heart to slow down heart rate. So if you combine a non-dihydropyridine with a beta blocker, you can precipitate heart block and even cardiac arrest, okay? So beta blockers are not to be combined with a non-dihydropyridine calcium channel blocker. This can cause asystole. Other conditions, other medications can include ACE inhibitors if they're hypertensive. And remember, patients who are diabetic and hypertensive, the antihypertensive of choice in diabetics with hypertension is ACE inhibitors. So that's a good combination there. And of course, statins in the event that the patient has dyslipidemia. Now, what I saw came for MBBS, and this is what you want to write down, is that isosorbide dinitrate is a long-acting nitrate, and a main side effect of that is headaches, right? Nitrates, your GTN, which goes under the tongue, that's short-acting. Your isosorbide dinitrate, that's long-acting, and the side effect is headaches. That came as a simple question. Which of these is a side effect or some kind of thing? Isosorbide dinitrate, side effect headaches, just correlate the two. Ivabradine can be used in patients who cannot tolerate beta blockers, or in the case of heart failure, who are maxed out on beta blockers. So ivabradine is procoralan, that's an alternative to beta blockers. It works by a different mechanism to decrease the heart rate. It works on the at the cellular level, on the potassium sodium channels or something like that. Can't remember the exact physiology, right? But it's an alternative to those who cannot use beta blockers or have maxed out on beta blockers. And the last thing is statins. Statins may cause rhabdomyolysis. Never forget that, please. Patient on all these meds coming with muscle pain, the statin is the answer. Okay? Statins cause rhabdomyolysis. So let's talk about rhabdomyolysis as our by the way here, because it's also commonly tested. So let's see if we can do this, right? Because this should be definition up of stable angina. NSTEMI, unstable, and STEMI and thing is easy to teach. So let me just, by the way, for rhabdo, am I muffled again or you all hearing me? Because I switched the screen.
We're hearing you.
All right, thanks, Gonzalia. So, what do we need to know about rhabdomyolysis? So this is by the way, rhabdomyolysis. Very easy to understand. Now you're never going to forget it. Rhabdomyolysis, this is going to be the skeletal muscle here. Rhabdomyolysis, muscle breakdown. What does muscle have in it? It has myoglobin, sorry. It has creatine kinase, and it has potassium, and it has phosphate. So therefore, we could kind of precipitate and predict what's going to happen here. So when we have severe muscle breakdown, statins can cause rhabdomyolysis. Cases where we see rhabdomyolysis would be things like trauma, seizures, electrocution, the full works, anything that could cause muscle breakdown, right? Once you have that muscle breakdown, this myoglobin, oh my gosh, I erased my whole thing. Let me undo that there. This myoglobin is going to be one of the main concerns. Myoglobin is toxic to the kidneys, right? So myoglobin can cause an acute kidney injury. There are two mechanisms. It's cytotoxic. It causes vasoconstriction, and I can't remember the third mechanism. It causes renal artery vasoconstriction as well, right? But basically, myoglobin damage to the kidneys. It's filtered by the kidneys. It damages the kidney. But once it's filtered out, it causes myoglobinuria. Okay. So rhabdomyolysis would present with what? Dark urine. Good. We also said that the muscle contains potassium. So there's high amounts of potassium in the muscle that is released from when it's broken down. So the patient would have a hyperkalemia. But why else might they have a hyperkalemia? Well, for the very same reason. They have an acute kidney injury. So rhabdomyolysis, we want to monitor our potassium levels as well, because the muscle breaks down potassium, and the muscle breakdown releases potassium, and the kidneys not working properly. It can't excrete potassium, so we have a hyperkalemia. This hyperkalemia